be discussing about translating science to...
Arundhati, take your time. You must have prepared. We have Dr. Abhay Shah after you. That's all. With that, we'll finish.
Okay.
Thank you. And thousands have logged in to listen.
Okay. So basically, what I have been given is translating science to practice, and what are the clinical perspectives of generation 2 basal insulin. When you're talking about translating science to practice, that's a very, these are just 4 words, but these are very important words, because there is so much that we have evolved in terms of the science of the treatment of diabetes. But whether that has translated from the books or the knowledge or the web to our clinical practice, our day-to-day practice, is something that we know that it has not really happened the way that it should have. The lacunae between science and practice still exists to a large extent, and that is the gap that we will try to kind of cover up and narrow down. The basic purpose of all these meetings is basically to narrow down the gap between science and practice, and today I'll be talking about generation 2 basal insulin. Now, these are aspects of insulin therapy that we are all aware of, but at the same time, I feel, and I guess all my seniors would agree, and juniors also will agree, that these are points that need to be reiterated in our mind again and again and again. Because the impact of delayed insulin initiation is immense in the total outcome of the diabetes treatment. And we are talking day in, day about the timely initiation of basal insulin, but it's not happening. And today what we'll try to take a look at is basically these 2 aspects, along with when you're talking about generation 2 basal insulin, is there any particular benefit that we are offering to our patients? If so, is it, is the cost benefit ratio good enough? Is it worthwhile to think of initiating generation 2 basal insulin instead of 1? And what are the practical considerations for the use of generation 2 basal insulin? Talking about the impact of delayed insulin initiation. Now, we are aware that there has been a trial which is known as a landmark trial, and a lot of doctors from across the country, 382 sites actually, have been a part of this study, which was a large scale, it was a longitudinal prospective real world study. And the basic intention of the study was to investigate the management of the complications in type 2 diabetes across India over a period of 3 years. Now, as you can see there, what were the basic...
Your slides are not moving.
My slides are not moving? Can you not see?
No, yes, no.
Now it is come.
Oh, okay. Can you see this now, the landmark?
Yes.
And the next?
No.
Oh.
Maybe, ma'am, in full screen mode, it's not moving.
Okay, so what I'll do is, I'll keep it this way. So that'll be easier. I hope they are visible now. So this is the landmark, and these are the highlights that came out from this study. Very disappointing statistics, actually, that 4 out of 5 people in India who have type 2 diabetes have uncontrolled diabetes, right? Secondly, less than 1 in 4 Indians with established type 2 diabetes take insulin. And I think every one of us know how that, I would in fact assume that the numbers would be higher, because it is so very difficult to convince people to take insulin. And the third point is basically a point which has an onus on us, doctors, the treating physicians, that the average HbA1c at which insulin is initiated is 9.2%. So we cannot put all the blame on the patients, because here is where our action starts. Unless the HbA1c goes really high, or a lot of molecules have been used up and still we're not reaching results, many of the doctors will not even think of initiating insulin. Delayed insulin, we have known about this, but again, I would want to reiterate, generally, there is a significant delay from where insulin is needed to where insulin is used. So you can see, the time from the start of regimen to intensification also. So from 1 OAD to 2 OADs and 3 OADs. So not only are we initiating insulin in a delayed manner, we are also intensifying insulin much slowly or much less aggressively than we need to do. And as a result, the implications are on a bad metabolic memory, right? A bad metabolic memory leads to all of it. We know the oxidative stress, the advanced glycosylation end products, the collagen linking, all of it leading ultimately to the chronic diabetes complications. And that is why, in spite of all our knowledge that we have about insulin today, in spite of all our knowledge that we have about diabetes control, HbA1c tightening, we're still at very poor figures when it comes to chronic diabetes complications. And that is where we really need to take a hold on things and start off insulin from the point that we think that insulin is needed, and not allow it like another 6 months or another 6 months and so on. So these are the drawbacks of the delayed insulin initiation in terms of microvascular complications, in terms of macrovascular complications. The drawbacks are immense, and they are kind of moving forward in a categoric manner. Now, when we're talking about initiation of insulin, basal insulin is what is recommended in most of the guidelines. It would depend which kind of insulin you are initiating, but a lot of times initiation with basal insulin with maybe an up titration of the OAD or an adjustment of the OAD often does the trick, because we have had the concept of fixing the fasting first and then going on to the basal, depending, of course, again on the fasting and the PP levels of at that point. This is about the early initiation of insulin, which significantly has an effect on the metabolic control. And we've known it all along. From the Wikipedia's study onwards, we've known that the concept of metabolic memory and how insulin significantly changes that. And this is one slide that is shown at least 10 times in every, I think, conference, which is telling us about the importance of the aggressive intervention and how we should start off with the aggressive treatment from the very word go. Now, when we're talking about an early basal insulin initiation, this is the B-SMART technique. We're talking about the basal early strategies to maximum HbA1c reduction with both oral therapy. So that's BOT, the basal and oral therapy combined together. It is a convenient insulin regimen. It's a convenient, it's an effective regimen, of course. You could choose your doses depending on the fasting level, depending on the body weight, depending on your clinical discretion. But generally, this is what is said, that you could start off with 0.1 or 0.2 units per kg per day, depending on the degree of hyperglycemia, or flatly at 10 units. But that is something that we generally do not do. We kind of, decide the dose based on the sugar level that the patient has and the body weight of the patient. You could decide to inject the basal insulin either at night, which is the usual protocol that is followed, but you could also give it in the morning, because now that we have so many, options available with more flexible insulin, with insulin that are more broad-based, that act over a much flatter insulin. So we can decide on our, dosing timings according to the convenience of the patient. Flexibility of timing is one thing that has really, really helped us convince patients, convinced ourselves, and adjust the dose, and made it much more simple for use, less intrusive. The very concept of, that insulin is cumbersome. I have to take it 20 minutes prior or after, whatever we had, the problems that we had earlier on, or there were certain timings that you needed to, confirm to, that those have kind of gone out. And when we're telling our patients that it's okay, you can take it at any time, it's all right. Even if you forget it at that particular time, you can take it an hour later or 2 hours later or earlier. And that really helps them in kind of accepting insulin better, and helps us in putting insulin in place at earlier. Now, if you have decided to initiate basal insulin, what do you do with the other OADs? Metformin obviously can be continued if there are no specific contraindications. The newer therapies, the SGLT2 inhibitors, the incretin-based therapies can very well be continued. If the patient is on thiazolidine, there would be a concern about increased body weight. So probably the concomitant use of thiazolidine and insulin is not really a combination that we kind of encourage a lot. It can be given at times. It's not that it cannot be given, but preferably because of the body weight and other factors, the PD demand, the others that are there, that should be reduced or discontinued in favor of other molecules. What a lot of people say is that if you're initiating an insulin, you stop the sulfonylureas, but a lot of times you cannot really do that because sulfonylureas are potent agents by themselves. Now, if you take away the sulfonylureas and you're putting only a basal and you're taking away the sulfonylurea in the morning, that might kind of actually lead to poorer glycemic control. So maybe what you should do is decide based on that individual patient's condition, but you could reduce the use of the dosage of the sulfonylurea if there is a concern about hypoglycemia. What are the benefits of early basal supported oral therapy? Not when all 3 groups, 4 groups have been used and there is nothing else to give, and then you're telling the patient that, okay, I have kind of exhausted all my treatment, this is what I can give you. Not then. When you have used maybe 1 or 2 drugs and you think there is a scope of using a 3rd drug, but you choose to prefer a basal therapy there, that is where you are basically providing the patient with the chance of restoring some of the residual beta cell function over a short period of time. You could decide to use that for a short period or for a longer period. And of course, about the attenuation of the microvascular complications and, with a lower risk of hypoglycemia and weight gain, which have been major concerns with the use of insulin. With the advent of basal therapy, that has gone down a lot. And today, when we are talking about the next generation, the way forward with basal insulin, the generation 2 basal insulin, there we are talking of added benefits. Now, what are the generation 2 basal insulins? There are 2. There is glargine 300 and there's the degludec. The basic concept is that these are, basal insulins that have come a lot after the initial basal insulins were introduced. Remember, NPH came in 1946, and it took so many years till 1992 for a basal insulin to come in. And then you had glargine and then you had detamil. By 2010, we had degludec, which was a new concept. We are talking about less variability, more prolonged action, a flatter curve. And then we had glargine 300 in 2011. So these 2 molecules, the degludec and the glargine 300, are actually a way forward that have been developed to overcome the limitations of the generation 1 basal insulin. So if you're talking about glargine 100 and glargine 300, basically what is the difference? The same molecule, which has been kind of condensed. The molecular structure is the same. It just forms precipitates, and the metabolism is such that because it is forming a precipitate, it is released slowly, and thereby it acts for a longer duration of action. And there are no major peaks. It is much, much flatter as compared to the glargine 100. So the absorption kinetics is what is basically different, with a more gradual release with glargine 300 as compared to glargine 100. So what does that result in? When you're looking at the PK/PD profile of these patients and you're comparing glargine 100 with glargine 300, there is basically a stable and prolonged action which offers you an injection timing flexibility of plus minus 3 hours. So earlier on we were saying 9 p.m. or 10 p.m. So now what are we saying? We are saying you can give it at 7 p.m. You could give it at 10 p.m. You can go ahead and give it at 12 p.m. So that greatly enhances the flexibility of the insulin for the patient and makes it much easier for them to take your offered insulin in their day-to-day life. So, and when it comes to what are the benefits that we are talking about, why, apart from that flatter profile, what is it? Are we seeing benefits in terms of weight gain? Because flatter profile basically will translate into lower hypoglycemia. That is what is expected. So are we seeing that in our studies? Are we seeing that in the real world evidence? So what have we seen? Yes, sustainable HbA1c reduction, much lower hypoglycemia, and weight gain was also seen to be much less. Now, there have been a number of studies that have been done across with the different generation 2 with the generation 1, which, there have been the benign trials and there have been the addition trials where glargine 300 and degludec have been compared to glargine 100 with much lesser incidence of hypoglycemia, as you can see. I'll just briefly touch upon the special population areas here, because these are also areas that you would want to know that, am I offering any benefit if I'm giving a generation 2 in place of a generation 1? So first of all, the CVD, population which is at a higher risk of CVD or has CVD, Now, what was said that because glargine 100 has established the CV safety, there is no reason, the regulatory body said that there is no reason to carry out another CV safety trial with glargine 300. But having said that, there has been a look at, or a relook at some of the data that is there, where we have compared glargine 100 and glargine 300, and it has been seen that the second generation analogs are safe and effective, and lesser hypoglycemia in general and nocturnal would translate into a CV safety benefit. Obesity, we must remember that both the addition and the begin pivotal trials had obesity, because the average BMI was 34.8 in the addition and 30.1 for in the begin trials, and there were no concerns with the use of the second generation basal insulins in these populations with type 2 diabetes and obesity. In hospital patients, would you prefer a generation 1 or a generation 2? Now, there have been a few published studies which have compared, the insulin initiation with the second generation versus the first generation. And though the general hypoglycemia did not really differ in these in-hospital patients, the frequency of nocturnal hypoglycemia was significantly lower in the 300 group as compared to the 100 group. Now, there have been concerns about hypoglycemia and the use of degludec, though a real-world study did find that, somewhat higher incidence of hypoglycemia with degludec versus glargine 300, and they hypothesized that, it was the serum albumin level which was responsible for this, because they found a negative correlation between a 24-hour hypoglycemia and the serum albumin level. And thereby it has been said that if a patient has a low serum albumin level, and that has been corroborated by another study by Kawaguchi, that the mean percentage of time with hypoglycemia would be expected to be lower in those with glargine 300 as compared to ITEC. But then again, we must remember, these are small studies, but these have been hypotheses that have bbeen put forward. Another area which we might not think to be very important, but is very important for the patient, of course, is the pain that is associated with the injection. Because these are one step ahead, the pens are also better. The pens are such that they are easier to use, and patients have reported lesser force to inject, or lesser pain, ease of use. These are the points taken from the patient's perspective. He's not understanding this flatter curve and all these things. He's understanding my flexibility of use. He's understanding lesser pain. He's understanding, lesser hypoglycemia. He's understanding lesser weight gain when you're telling him. So these are points from the patient's point of view. And all in all, thereby, where we stand today with the availability of the generation 2 basal insulin, definitely a lot of advantages being put forward by the studies, initial studies, the pivotal studies, and then subsequent studies, and now the real world data. Longer duration of action, greater flexibility, glycemic variability. We've recently had the in-range study, which has shown us the reduced glycemic variability with the use of basal generation 2 insulin, easily titratable, lesser hypoglycemia, leading to more patient satisfaction and lesser concerns about weight gain. Some practical considerations. What is the initiation dose? Again, I'll say this is very, very individualized, but it has been put forward as 0.2 units per kg. Preferred timing of injection, any time of the day, but at around the same time, not like today you've taken in the morning and the next day you've taken at night. All OADs can be continued, can be safely titrated maybe once in 3 days or with weekly titration schedules, as we've done with the generation 1. And up to what dose would you go up with glargine 300? Up to 0.5 units per kg per day has been put forward. And what are the advantages over the first generation? Obviously, the ones that we've discussed, variability, flexibility, hypoglycemia, weight gain, and safer titration. This is one a slide that I got from one of the company people, because this seems important, because when they told me that this is associated with lesser pain, I had to understand why is it associated with lesser pain. And so this is what they gave me, that okay, this is a 5-second hold time, which is less injection force, easy to use. Apparently we are also getting patient data telling us that yes, this is indeed an easier insulin to use when it comes to their compliance and their and these are dedicated cartridges and other things, the total capacity being 450. So summarizing what we have discussed is that early insulin initiation again and again is important to understand, is crucial to achieve effective glycemic control, and delay may may increase the risk of complications. So today we have the options about generation 1 and generation 2 basal insulins to start off as basal therapy. Generation 2 basal insulins that have come across have demonstrated, good glycemic reduction, are convenient with a lot of advantages that we have discussed, and therefore today remain a good choice when you're starting off insulin for your patients. And we are maybe going to see even better insulins come across to us today. But from where we have started off with the NPH insulin across the journey through the 100 glargine and the detamir to the 300 glargine and degludec, whatever we have in our hands today, that has indeed been a great way forward. And today, when we give basal insulins to our patients, we are a lot relaxed. We are not that concerned, and that is probably why we need to increase the use of insulin in our day-to-day practice.